This is Endocrine Feedback Loop. I am your host, Chase Hendrickson, and welcome you to this Journal Club podcast series brought to you by Endocrine Society. Thanks for joining us as we explore an important article recently published in one of the Society's clinical journals. Welcome back to the Endocrine Feedback Loop podcast for our 26th episode. For today's episode, we return to the JES to look at a study examining the different modes of radioactive iodine preparation for the treatment of metastatic differentiated thyroid carcinoma. The authors' results may impact how we treat these patients, so we will want to consider them carefully, in part because this is an observational study and so has some intrinsic limitations. We will discuss the methodology in detail, but always with an eye towards how the findings may affect our clinical practice. As usual, you have three endocrinologists for the discussion today. I host the Endocrine Feedback Loop and work at the Vanderbilt University Medical Center in Nashville as a general endocrinologist, medical director for our endocrinology clinics, and associate director for our fellowship program. Back again as our regular contributor to review this article is Amali Saracina from Temple University in Philadelphia. She too is a general endocrinologist as well as a director of their fellowship program. Joining us today as our guest expert is none other than Mike Tuttle from the Memorial Sloan Kettering Cancer Center in New York City. He serves as chief of the endocrinology service at MSK and is one of the world's experts in thyroid cancer. Numerous publications, work on guideline committees, and invited presentations speak both to his expertise and how in demand he is on the topic of thyroid cancer. I'm thrilled to have both of these folks join me today and welcome them into our virtual recording studio. As always, everything said is our opinions only and not necessarily those of our respective institutions or the Endocrine Society. For this month's episode of the podcast, we look at metastatic differentiated thyroid cancer survival is unaffected by mode of preparation for I-131 administration. The Journal of the Endocrine Society published this article in May 2022 with Christiane Gomez Lima as the first author, and most of the authors coming from the MedStar Washington and MedStar Georgetown hospitals. Amali will now walk us through the author's introduction as she and Mike also help give us some important background on thyroid cancer and radioactive iodine. Amali?
Thank you. I'm very excited to be here today. So radioactive iodine, or RAI, is a mainstay in the treatment of metastatic thyroid cancer. So right off the bat, we wanted to ask Mike, can you give us an overview of radioactive iodine therapy for thyroid cancer and how the thinking has evolved?
Yeah, it really has evolved over the last sort of 20 or 30 years. We've had radioactive iodine since the 1940s or 1950s. I always laugh at oncologists when they say, we found a new targeted therapy. And I say, well, congratulations. We've had it since 1940, targeted specifically at tumors that grab onto radioactive iodine. We knew in the early days that some metastatic thyroid cancer would grab onto radioactive iodine, and early on learned the importance of being on a low iodine diet and TSH stimulation to make that happen. And over the years, initially, obviously, we had to do thyroid hormone withdrawal, and we would stop thyroid hormone for about 6 weeks or so. And then, as we'll talk about today, the advent of recombinant human TSH allowed us to raise TSH for stimulated thyroid globulins and radioactive iodine scanning, and then radioactive iodine ablation. And today we're sort of exploring sort of the next frontier, which is, can that recombinant human TSH be used as the TSH stimulant for radioactive iodine therapy in the metastatic disease setting?
So as mentioned, recombinant human thyrotropin was initially approved by the FDA in 1998 for diagnostic purposes to identify residual tumor via the stimulation of serum thyroglobulin secretion with or without a concomitant diagnostic radioactive iodine scan. In 2007, the FDA issued approval for the use of recombinant TSH with radioactive iodine to perform post-surgical ablation of thyroid tissue in patients with differentiated thyroid cancer. Currently, neither the European medicine agencies nor the FDA approve the use of recombinant TSH for facilitation of radioactive iodine therapy in higher risk patients with metastatic differentiated thyroid cancer. However, based on cumulative experience, many physicians are using recombinant TSH to aid in radioactive iodine therapy for patients with metastatic disease. So there are several questions that the authors of this study brought up in their paper. And one is efficacy. Is use of recombinant TSH as efficacious in treatment of thyroid cancer. And the same authors published retrospective study analyzing the efficacy and side effects of thyroid hormone withdrawal versus recombinant TSH and reported similar efficacy between both methods. Another big question is safety. If you look at the ATA 2015 guidelines, they note extreme or prolonged elevations of TSH from either method could stimulate tumor growth and size of metastasis. And it mentions to take care if there are mets in the brain or spinal cord, as swelling could compromise neurologic function. And the authors of these guidelines said there was no recommendation and insufficient evidence to recommend the use of recombinant TSH in metastatic disease. So, Mike, we wanted to ask you your impression of the data prior to this study on the use of recombinant TSH in the space.
A couple of thoughts. One, if you look at where it's been approved in terms of recombinant human TSH, it's really in the diagnostic setting and then in the ablation, which is destroying normal thyroid tissue by and large. And we know normal thyroid tissue grabs onto radioactive iodine like 100 times better than thyroid cancer. So you could easily make the case that, yes, you could destroy some normal thyroid tissue, but the thyroid cancers that don't concentrate radioactive iodine doesn't necessarily mean that it would work there. Now, that being said, many groups around the country, include our group and other groups, have used recombinant human TSH in the setting of metastatic thyroid cancer. And as a general rule on sort of preliminary data, we think it probably works the same. I mean, you're not going to get FDA approval for probably works the same. To be fair, nobody ever asked the FDA for approval or the European agency for approval. So it's not like they said no. It's just the amount of money and time and effort it would take to get FDA approval for that is just never going to happen. So unfortunately, we're going to be stuck with these kind of studies that we have. So my general bias is that if you make somebody hypothyroid, you probably get a little bit more radioactive iodine into the tumors than you do with thyrogen. There's some lesional dosimetry data that suggests that. But then the question is, does it make any difference? Does hypothyroid get enough in that it would be therapeutic, or does it get just a little bit more in that just doesn't make any difference? So for efficacy, probably short-term data, probably about the same as where we were before this study. In terms of safety, the ATA guidelines, I think, got it right in that if you raise the TSH in people that have big metastatic disease, sometimes it swells. So the caveat there is fix those things before you raise the TSH. We radiate brain mets or resect them or radiate spine mets. In the distant metastasis setting, before we run to radioactive iodine, no matter how we do it, we're looking for those big lesions that need to be fixed with something so that after radiation or on steroids or after surgery, then you can safely raise it either way. Depending on who's paying me to give the talk, I could make you a pretty good case that the acute rise with the TSH, with their common human TSH, would be worse, or a long, slow rise over many months would be worse. The reality is both of them make it swell. It's certainly a lot more dramatic when you see things swell on recombinant human TSH because they go from 0 TSH to 100 in a day. Tends to be a little slower on hypothyroid withdrawal. So I don't see a big difference in the safety. And I use that safety just as a reminder to all of us to fix big metastatic lesions if we can that are in worrisome locations before we get down the radioactive iodine pathway.
So the goal of this study was to conduct a retrospective chart review to compare progression-free survival and overall survival of patients with metastatic differentiated thyroid cancer prepared for radioactive iodine therapy with either recombinant TSH or thyroid hormone withdrawal. So why is this important? Well, current practice plans vary a lot, and I informally polled some of my colleagues about what they do in this scenario, and I got responses that, yeah, I know it's not approved, but we do it, to, well, it's not FDA approved and I'm not going to do it in my practice. I know that's what they do at Sloan Kettering, was the literal response I got. So, and we know that TSH withdrawal has more side effects, and there have been other studies looking at the effects of patient quality of life. But, for myself as a physician who treats thyroid cancer, but not high volume thyroid cancer, sometimes we are concerned about using agents, when we read those safety data. Obviously, we want to know if there's any metastatic lesions there beforehand, but sometimes it is concerning when we look at the literature.
Great. Thanks, Emily. I think that's really helpful to understand where the data is right now, the uncertainties that exist, not just in the data, but then also in the practice of folks who are taking care of these patients. And Mike set it up nicely as saying, well, sure, we would love to have an RCT, but that may not be very realistic. And so we need to grapple with the data that we have and decide, hey, is this good enough that we can change what we do? Or do we just have to say, yeah, we can't use this? So that's really important for us to keep in mind. So now we're going to dive into this data and try to answer those questions, or at least see how does this add to the body of literature that's out there already to help us answer that question. So first of all, as we normally do, we're going to take a bit of a step back and think about the way the study is set up. So that will help us understand the intrinsic limitations. And so that way we can look at how the authors deal with them and what we think about that. So first of all, the study design that's used here is a retrospective cohort study. So the way that works is, first of all, the retrospective aspect that involves the data collection. So that means that the data was collected after everything has been done. The limitation that goes along with that is you're stuck with whatever data is available. So if there was something else that you wanted, but for whatever reason it's not in the charts, it wasn't extracted, it's not in the database, then you're not likely going to have access to that. And how a cohort study works, and this will be the important part for us to think about, is it begins by splitting subjects, individuals, into at least two groups. And traditionally, it's an exposed and an unexposed group. Here, it's going to be just two different types of exposure. And then what makes it a cohort study is that it follows these individuals over time to see if one group versus the other develops an outcome of interest more than the other one does. And so here, we're going to get to it in just a second, but the exposure is going to be how you were prepared to receive radioactive iodine. So a different, not yes or no exposure. And so we're going to think about that. And a key to remember here is that how you ended up in one group or another is not random. That's in an RCT, a randomized control trial. And that's one of the strengths of it is that it doesn't depend on somebody else. You got randomized into one group versus another. In cohort studies, something else made it happen. And it could be as hard to pin down as where you live. It could just be a local practice pattern. It could be something about the patients themselves who drove that or asked to be treated a certain way. It could just be a practice pattern of the individual physician that they were seeing. So there's a lot of different ways, and we often don't know exactly what that is. But key to highlight, it's not a random allocation of who gets treated one way versus another. Okay, so now back to this study. So first of all, the population that's being examined. So these are all individuals with radioactive iodine avid metastatic thyroid cancer. And these folks were seen at either the MedStar Washington or the MedStar Georgetown University hospitals, and quite a few years that they included here from 1996 all the way up to 2017. And to go back to the exposure as it's used here, it's how you were prepared for the radioactive iodine. All of these folks got radioactive iodine. That's the cohort in general. But how you were prepared split you into one group versus another. So one of them was that your preparation was with thyroid hormone withdrawal alone, or the other group is that you were prepared with recombinant TSH alone. So a quick word on how that worked. So the withdrawal, you had to be off of thyroid hormone for at least 4 weeks. And then with the recombinant TSH, you got 0.9 milligrams intramuscular for 2 days. So pretty standard there. Now, how you decided which one you got. So that was, as the authors described it, based on attending physician preference. And so I'd say that really is going to be where potential confounders show up, because we don't really know what that was. It's possible that attending physician preferences is that this attending always does it this way. So anybody who happened to get assigned to see that physician was going to get treated that way. Or it could be something else is based on the characteristics of the patient's disease or some other driving factor is the decision was made to treat somebody one way or the other. So that's what we have to keep in mind, because we don't really know what drove that decision. However, all of the individuals did have a low iodine diet, and they had urinary iodine levels measured to confirm that was effective for them. They all had their post-therapy scan day 7 to 10, somewhere in there. And they all also had a TSH check prior to getting the radioactive iodine to make sure that it was an appropriate range. Now, one word about individuals that were excluded here. So the authors had to wrestle with something, as they had a group of individuals who initially had their preparation for radioactive iodine with thyroid hormone withdrawal. But then all of these individuals required a second dose. And with that second dose, they were prepared with recombinant TSH. So I wanted to open this up as a group. And the authors do wrestle with this. They struggled a bit with what to do here. But just to get our input, and Mike, maybe we'll start with you and get your thoughts on this, because I think it does raise some issues in having to exclude these individuals from this analysis. So any thoughts about that in particular and how the authors handled that?
Yeah, it does raise some issues, and it may exclude a large proportion of the patients that we see, particularly if they're going to get a retreatment, right? So exactly as you said, they decided they wanted the purest cohort they could, which was thyroid hormone withdrawal only or recombinant human TSH only. We published a similar paper to this back in 2011, and I elected to make it 3 cohorts. And I included this one as the 3rd cohort and just described it as hypothyroid before we got recombinant TSH and then after that. So it's kind of a mixed bag. But we included it as a 3rd group and said, it's still going to be informative to us. If folks like some of Amali's friends that have never done recombinant human TSH, as soon as they decide to do that, they're going to have the question, well, now it's second line, and did we do hypothyroid? So I thought it was important to include those groups. So I'm glad they decided to include that group. I'm perfectly fine with not using them as a comparison. So I'm glad they just didn't exclude them as a black box, but did put that information in there so we could look at it. So, I think that's just rational design choices you make when you design one of these studies, and everybody could do it a little bit differently.
Yeah. And Molly, thoughts on that?
No, I agree that the authors did later mention that you really can't compare these patients to the ones that got exclusive treatment because their previous therapy is going to have a confounding effect. But they mentioned that these patients are frequently seen, and that's why they wanted to not exclude them completely, which I thought was reasonable.
And from a non-perfect view of the world, who cares whether their outcomes were good, thyroid hormone versus recombinant human TSH? I understand that's the research question, but if their outcomes and overall survival was good when you used it afterwards, then we'd go, okay, I can't tell the sequence or I can't tell what was good or bad, but reassuring that the outcomes would be the same. So I totally understand when you're trying to sort of figure out what's the most pure research question. You throw the two together, you can't separate them out. And then clinicians like me that just accidentally do research go, don't care. These are patients I'm taking care of. Is the outcome anywhere near the same?
Yeah, I agree. I think the authors did a good job of explaining that and building a case to say, hey, it's not ideal, but we got these folks, we got to do something with them. So I agree with that. I think the only thing we'd have to keep in mind with that is all of these folks required a second dose. So that means that somebody was concerned that that first dose wasn't enough or they needed further treatment. So you're potentially taking a subset of folks who at least initially were prepared with radioactive iodine and folks who didn't respond wonderfully to that single dose because they required a second dose. So you maybe are excluding folks who had a worse outcome. So it could make the thyroid hormone withdrawal group look a little better because you took these folks out. But I agree, you had to do something with them. So it does seem like that was the right thing to do.
You're exactly right, Chase. And oncology deals with this all the time, right? And the language that oncologists use is first line therapy versus second line therapy versus third line or fourth line, so that you have that reminder if it's second or third line therapy, these patients are sick enough and didn't respond to the first two to be part of the third. So I think that is certainly a confounder when you're trying to compare it with anything. And I think probably wise the way they did it was just describing that as a separate cohort and laying them out so that people would go, okay, I want to know about this group of patients. So I think they struck that nice balance in the middle of not a direct comparison, but also not a black box that we'd be criticizing them about what happened to these people, right? So
good. So that's our exposure. So 2 main groups and then this side group that we're also going to look at just a little bit. So now we're going to think about outcomes. And this is where we really need Mike's help to help us think about this. He mentioned oncologist already. So we're going to get really into stuff that sounds a lot more oncology than it does endocrinology. But this is thinking about outcomes as they're described based on the RECIST 1.1 criteria. So I'm going to list these and point out which are the main ones here, but we're going to have Mike help us think about really what these mean, what are the important ones, what we need to be focusing on. So the outcomes that were looked at here, so the authors described them. So the first one's complete response. The second is partial response, and then also progressive disease. The fourth one would be stable disease. And then the last two, they're the particularly important ones. The primary endpoint was progression-free survival, and then a secondary endpoint of overall survival. So Mike, help us out there, kind of maybe give us a quick overview of what those mean, or at least which ones we really should be focusing on, because in thyroid cancer, these are the ones that seem to make the biggest difference, or should we focus on?
Yeah, and I think, it's very good to use the RECIST criteria in these oncology languages. We've been dragging thyroid cancer from endocrinology into the oncology arena, right? We talk about remission now, we talk about response to therapy. So a lot of us, I think, honestly, because we work at cancer centers and we're used to this language, it just became normal. So that whole RECIST criteria is long-standing in oncology. When you think about giving somebody a drug and saying, did it work or not, how do you sort of measure that? And this is a long-standing way of doing it, where they basically take about 5 different lesions, metastatic lesions throughout the body, no more than 2 per organ, and what's their maximum diameter, and you add all of that up for those 4 or 5 lesions. And then when you look at your response in 2 months or 4 months or 6 months, you add up all those same 4 or 5 places, add up the maximum, and they'll call it the sum of the diameters. And that's what changed. So amazingly enough, that really does predict outcomes and stuff in oncology. And so it comes with like complete response is easy. Everything is gone. And partial response is the sum of those diameters of however many you measured decreased by 30%. And if it progressed, it increased by 20%. And if it was stable, it was in the middle. So it's a nice way to be able to think about when you compare radioactive iodine with other systemic therapies and Lenvima and sorafenib and all those sorts of things. It puts it in that context. Not so critical for us for this purposes. The critical thing for us, I think, is progression-free survival. That's basically from the time of the last radioactive iodine until something changes. Something new or something that you knew about got bigger, right? You can't talk about recurrence here because these guys had persistent disease because we're treating their persistent disease. So progression-free survival is when something grows on a CT or MRI. And overall survival is usually from the time of diagnosis. Surgical papers describe it as the time of surgery. Nuclear medicine papers define it as the time from their first dose of radioactive iodine, which is what happened here, to either the time of death or the time of their last follow-up. So we're going to talk about this. This is a relatively short study with follow-up about 5 years. So I think the most key endpoint on this is progression-free survival. Did we stop things from growing? Did one cohort have more disease growing than the other? Overall survival is tough when you've got relatively short follow-up in thyroid cancer. So to me, I'd be looking at, did you get any complete responses, which basically never happens in this setting? But more importantly, what did we do to their progression-free survival? When the patient comes back, you can go, you're stable, hang in there, come back and see me in the future.
That's helpful, and sounds like from your perspective really makes sense that progression-free survival was the primary endpoint. Everything else is extra that we throw in there, but have focused on the right thing. Good. So that's helpful to know. We're going to keep those definitions in mind. Molly's going to walk us through a bunch of data in the results section, so we'll have to think about where to put these with all the different definitions. So we'll think carefully about that as I turn it over to her.
As mentioned earlier, these were patients from 1996 to 2017. There were 124 patients with metastatic differentiated thyroid cancer that were treated with radioactive iodine. So patients were excluded for a few reasons. So one was lack of follow-up data, 21 patients. And the authors noted that since they are a tertiary referral center, some patients may have gone back to their initial referring provider. Another reason for exclusion was non-radioactive iodine avid metastasis, 25 patients, which certainly makes sense. Another exclusion criteria was younger than 18 years at first radioactive iodine therapy, so 6 patients. Another 4 patients were excluded because of incomplete data from the beginning of their disease. And then, as already mentioned, there were 13 patients who had thyroid hormone withdrawal first, followed by recombinant TSH, and they were described separately. So this left the authors with a final cohort of 55 patients, 39 of whom were women. And as Chase had already mentioned, since this is a retrospective trial, we want to analyze if the two groups are different in other ways that may skew the results. So interestingly, it was almost 50-50. 49% received recombinant TSH and 51% received thyroid hormone withdrawal. The recombinant TSH group was older with a median age of 59, the range of 47.5 to 65.5. Versus the withdrawal group, who was quite a bit younger with a median age of 41 with a range of age 30 to 63, and that was statistically significant. So when we looked at the cohort further as to what type of thyroid cancer they have, the majority, 76%, had papillary thyroid cancer, either classic or follicular variant. 6 patients, or 22%, had follicular thyroid cancer. And then 1 patient had Hürthle cell, and another 1 patient had poorly differentiated thyroid cancer. So a big question that was alluded to earlier, do these groups vary on something different, such as their tumor characteristic or their metastatic disease? And the authors found that there was no statistically significant difference in the pathologic features between the groups, tumor size, histological type, or extrathyroidal extension. And all patients had distant metastasis, though they did note that more patients in the recombinant TSH group had macronodular lung mets than in the thyroid hormone withdrawal group, 14 versus 6, with a p-value of less than 0.05. And because in the American Thyroid Association guidelines, they had mentioned the concern about neurologic complications with METs in that area, the authors do note that 2 or 7% of the patients in the recombinant TSH group had brain metastasis versus 1 patient or 7% in the thyroid hormone withdrawal group. And I didn't see any mention of spinal metastasis in the paper. Another question was there a difference in the TSH level obtained between the two methods? And the authors noted that both groups had elevated TSH levels, but as we might expect, there was a higher TSH in the recombinant TSH group, median of 112.7 versus a TSH of 68.9 in the thyroid hormone withdrawal group. So again, quite a bit higher TSH in those people that used recombinant TSH. So did the two groups differ in the radioactive iodine treatment they got? As Chase mentioned earlier, everybody got radioactive iodine treatment, and we're trying to look at the way they were prepared, but was there something inherently different in the radioactive iodine treatment they received? And the authors saw that there was no statistical difference in radioactive iodine activity used in the first therapy in both groups. But in the recombinant TSH group, the majority, 24 out of 27 or 89%, received a dosimetry-based therapy. On the thyroid hormone withdrawal group was fewer, 14 out of 28 or 50% who received dosimetry. So Mike, we wanted to ask you to comment on this difference of the dosimetry being used more often in the recombinant TSH group and why it may have differed between these two groups.
I think it just shows you the intrinsic bias. By dosimetry, what we mean is we can measure how fast the radioactive iodine is leaving your body. Give you a little tracer dose of radioactive iodine, and then every few days, measure some blood tests and some scans and see how much radioactive iodine do you have left in your body and in your bloodstream. And we can use that to calculate what's the maximal administered activity that I can safely give you without hurting your lungs and bones. And traditionally, MedStar and Doug Van Nostrand have done that for dosimetry. We learned how to do it at Walter Reed. And then when I went to Memorial Sloan Kettering, we routinely do that. So I think what you saw was the ones of us that were early adopters of using recombinant human TSH were very comfortable doing it because we had dosimetry studies. We knew the clearances, and so we weren't sort of flying blind, while the traditional thyroid hormone withdrawal is the old way that we did it with dosimetry. Now, one of the things you have to be careful with is just because I do a dosimetry approach doesn't necessarily mean I change my administered activity. Everybody always thinks that dosimetry tells me what administered activity to give. It doesn't really. It sets the safety limit. What's the maximum dose? And in young people, sometimes the maximum dose is 600 or 700 millicuries. I'm probably not going to give that to a 20-year-old, right? So the dosimetry just kind of gives you some safety parameters, but then there's still a lot of individual decision making. So I think less likely that the dosimetry base made a difference, but you saw subtle things like the thyroid recombinant human TSH group being a little bit older, being macroscopic disease. You can imagine if you're about to make somebody hypothyroid, maybe you're more likely to make somebody hypothyroid that's younger. You know, our experience is they usually do pretty well, right? We've seen 20 and 30-year-olds that were hypothyroid that don't feel so bad. Some of the older ones had congestive heart failure and they had renal failure and good reasons not to make them hypothyroid withdrawal. And then even as Chase mentioned, subtle things like recombinant TSH costs money. It doesn't cost money to stay off thyroid hormone pills. You may miss more days of work. If you're on recombinant human TSH, maybe you miss a few less days of work. So there's lots of those subtle things that sort of select how you get into one cohort or the other. And then the last comment I'll make is with the TSH levels. People always compare the TSH levels and say the TSH level is higher when you do the recombinant TSH. That's true because it went from 0 to 100 or 200. But the real TSH comparison is the area under the curve. Those hypothyroid patients have had the TSH going up for 2 or 3 weeks. So it's maybe not the peak level that matters in them, but it's that longer progression. So if it takes the cells a few days or a week to sort of really ramp up to grab onto radioactive iodine, you could make the case that hypothyroid maybe would be better. If in fact it's a rapid phenomenon over a day or two and it's the peak values that matter, then maybe the recombinant human TSH would have the advantage. So I'm always a little reluctant when people compare the TSH values. We have to report them, but I wouldn't interpret one as being better or worse than the other.
So the authors also noted that there was no statistically significant difference in the mean number of radioactive iodine therapies and the mean cumulative radioactive iodine activity between the groups. And as already mentioned by Mike, the median follow-up time for the recombinant TSH group was 4.2 years versus 6.8 years for the thyroid hormone withdrawal group. So not a particularly long amount of time to look at some of these outcomes. So again, as we noted earlier, in regards to their outcomes, the objective of this study was to compare outcomes in high-risk thyroid cancer patients with metastatic disease who received recombinant TSH versus thyroid hormone withdrawal in preparation for their radioactive iodine treatment, specifically looking at progression-free survival and overall survival. For their primary outcome, progression-free survival, the authors found no statistically significant difference between the groups. They performed a multivariate analysis adjusting for age, sex, macronodular lung metastasis, number of radioactive iodine therapies, and cumulative activity of radioactive iodine. And after performing this, only older age at time of diagnosis was the only variable significantly associated with a greater risk of progression, which the authors mentioned is consistent with other literature. And so the thyroid hormone withdrawal arm had an odds ratio in regards to progression-free survival of 0.481 with a 95% confidence interval of 0.184 to 1.258. So again, their secondary outcome was overall survival. And the authors, again, found no statistically significant difference between the groups. They conducted the same multivariate analysis as they did for their primary outcome and demonstrated that older age at time of diagnosis and total cumulative activity of radioactive iodine were associated with a greater risk of death. They also looked at treatment response. So they compared the recombinant TSH group versus the thyroid hormone withdrawal group and basically listed the percentages of response. So within the recombinant TSH group, 85%, the majority, had a structurally incomplete response. 7% had an indeterminate response. One patient or 4% had a biochemically incomplete response, and another 1 or 4% had an excellent response. When you looked at the thyroid hormone withdrawal group, 57% had a structurally incomplete response, 4% had an indeterminate response, 18% had a biochemically incomplete response, and 21% had an excellent response. And the difference between the types of response was statistically significant. Now, as we mentioned earlier, they also looked at the target lesion, and this was, again, according to that RECIST 1.1 criteria that was mentioned earlier. And as Mike mentioned, no patient achieved complete remission, which is to be expected because these were patients that had known metastatic disease. But when we looked at other outcomes, there were several patients in both groups that had either a partial response or stable disease, which I think we would agree in this population are pretty good outcomes. And then when they looked at patients who had progressive disease, which is what we would be trying to avoid, there was no difference between the groups. And as mentioned, there was this third group of 13 patients who had thyroid hormone withdrawal, followed by recombinant TSH. And when they looked at this population, as we would kind of expect, these patients had more therapies by definition, and they had higher cumulative dose of radioactive iodine. And about 3 or 23% had a biochemically incomplete response, and the majority, 77%, had a structurally incomplete response.
Great. Thanks, Amali. So now we're going to take a step back. We're going to look at the discussions and conclusions. So we're going to take all those numbers that she went through, and we're going to look at how the authors wrestle with those and some of the recommendations that they make based on that. So first of all, we'll start with the quote from the authors of how they start their discussion. And they say that progression-free survival and overall survival of patients with metastatic differentiated thyroid cancer were statistically comparable, regardless of the mode of preparation for radioactive iodine therapy, either with recombinant human TSH or with thyroid hormone withdrawal. They point out that, as Mike pointed out already, that we don't have RCTs available for this, but this data does fit with the other observational studies that are out there. And they also mention, as Amali pointed out for us already, but they highlighted some of the independent risk factors that were identified. So they said, well, it doesn't seem to matter how you were prepared with radioactive iodine, but our data does show a couple of other things. And one of them is age. So that's something that's been recognized with progressive disease, that age is risk factor for that. Obviously, that makes sense as an overall risk of death, that age would be a driver there. And they also point out something that their data showed that was perhaps unexpected, that the total cumulative activity of the radioactive iodine was associated with an increased risk of death. Now, the authors hypothesize here that this is because of having poorly responsive metastases, and that those mets required more radioactive iodine doses, and that it wasn't actually a direct effect of the radioactive iodine activity itself. I wanted us to wrestle with that just a little bit, and Mike, maybe we'll get your thoughts on this. Does this make sense to you? Would you buy that, or do you think maybe we need more information? I didn't see that the authors provided the disease-specific mortality here, so I don't know if that's information that we would need to try to wrestle with that, or what would your thoughts be on how the authors grapple with that finding?
It's a challenge. I mean, I think if I was writing the discussion, I would have written the same thing. That's a legit thing to write. But one of the difficulties here is we don't have a control group. So we've got basically two different treatment arms. So if I'm being the optimist, I say these two preparation methods were equally effective. If I'm being a pessimist, I would say these two preparation methods were equally ineffective. Maybe they didn't work at all. Maybe they didn't change the natural history. This study couldn't answer that, but at least there was no difference between the two preparations. I think there are many patients that got way too many administered activities of radioactive iodine over the years, and they do tend to be the ones that were more poorly differentiated, and they responded a little, but not a lot. I think we can't entirely dismiss an effect of radioactive iodine. Now, the deaths that we've seen from radioactive iodine are very, very small, associated with secondary malignancies, and they're usually 15, 20 years down the road. So in a study that's 5 years, I mean, basically nobody gets leukemia within the first 5 years of their follow-up. So I think either attributing it to all the other comorbid conditions that the patient had, or attributing it to their disease. As somebody that's done these studies, it is really hard to figure out if somebody died of their disease or overall survival. These patients all had distant metastasis. What most of these patients actually die of is a post-obstructive pneumonia. So is their post-obstructive pneumonia overall survival, or is their post-obstructive pneumonia because of their big thing? So the ones of us that publish disease-specific survival, it really means people died with big volume progressive disease. So I never sort of challenge them. In fact, some of the senior thyroid community challenges people if they do try to do disease-specific survival. So it's so hard to know. So I think you just recognize that the older folks, they probably had a longer time of being exposure, but I doubt that in this cohort, the radioactive iodine was associated with a decrease in their overall survival, probably more of their comorbid conditions. And then lastly, if you look in the patients that are more than 55 years old with distant metastasis, their 5-year disease-specific survival is around 50%. So in those older patients with distant metastasis, these guys might do a little better because they selected the RAI avid patients. But, you know, the natural history of that cohort would still be a lot of deaths over that first 5 years.
And a comment that I would add, even though it wasn't highlighted by the authors, is that the odds ratio of that, so specifically that radioactive iodine activity being associated with a higher risk of death, the odds ratio was incredibly small. So while it was statistically significant, it didn't cross 1. It was just barely above 1. So even if that is truly from the radioactive iodine, it's likely not a big driver there.
Yeah, and that's important, right? Because we don't want to scare people away from radioactive iodine when it might be beneficial. So I tell them, yes, secondary malignancies, we can definitely measure it, particularly with multiple doses. But it's such an uncommon event with the first or second dose, I think the benefit outweighs the risk. So we have to tell them about it, but also try to put it in that sort of proper risk perspective that this is an uncommon event, even for people like me that for 30 years have been passing out radioactive iodine like candy. It's still really uncommon for me to see secondary malignancies.
All right, Mike, we're going to come back to something else that you mentioned just a little bit before. And so we're going to think about a couple of claims that the authors make. So I want us to think really carefully about this. So one of them in the discussion, the authors, and I'll quote them here again, they say that we also found that our patients benefited from radioactive iodine therapy, as shown by the number of patients with a partial response and with stable disease. I wanted to wrestle with that because you point out already there isn't a control group here. So they point out, hey, both of our groups, there were a lot of folks who either stayed stable or actually got better. And I think that's what they're drawing this conclusion from. But how do we think that the accuracy of that claim, knowing that there isn't a control group? So do we feel like from the rest of the observational data that's out there that this just isn't something you wouldn't see stable disease or an improvement on its own? Or do we say, if without a control group, we really don't know what would have happened without treatment? In other words, the natural history. So we really can't make a claim like this.
I'd meet them almost halfway through that sentence. So your point is exactly right, Chase. What would have been the natural history in these patients? And the natural history in a lot of RAI avid patients is actually stable disease when you do it by RECIST over 3 to 5 years. So the fact that you got stable disease, no, I don't think you can impute a therapeutic effect. The fact that they got a partial response, very unusual to see natural history to have shrinkage of thyroid cancer. Now, sometimes you can get shrinkage from previous doses of radioactive iodine, but a significant RECIST decrease in size. So I think their best data would be saying the partial responses they have is probably a treatment effect. Even with that, you'd have to control for TSH because we've seen tumors shrink with TSH. So stable disease, I'd say no. If I saw that sentence as the reviewer, I'd say soften that up a little bit. Stable disease could have been the natural history, but I think their partial responses that they got, particularly in the recombinant group, was pretty suggestive that they probably had some treatment effect there.
So help us out with something else. You mentioned dosimetry. You told us a little bit about that and your experience with that. So something that the author says, they say, we recommend a dosimetric approach to therapy to determine the optimal safe radioactive iodine activity to be administered to each individual. I want to be clear, the authors weren't claiming that their data showed this. However, whenever you see a recommendation in the middle of a discussion, if you're not careful, you can think that, hey, the data showed this and that's why they're recommending it. They seem to be making this more of as an editorial comment because they frequently do that. But what are your thoughts about that? Do you think the data that's out there clearly suggests that using dosimetry makes it safer for us to use radioactive iodine, as the authors recommend to us in their discussion?
Well, the nuclear medicine community that's listening to this will recognize you just asked one of the most biased people in the world about dosimetry. Now, maybe the only one more biased than me is this group of authors. So I come from a dosimetry background, and I often do the same thing. I put part of my religious points of view tucked in a discussion and hope somebody reads it. So it's an absolutely true statement that I think you can optimize the safety by doing the dosimetry. Now, in the vast majority of patients with the administered activities that most people give, dosimetry is not necessary. If you're going to be given 100 or 150 millicuries to people less than 75 years old, the dosimetry hardly ever tells you that that's not a safe dose. But we tend to give larger administered activities. We tend to give them more frequently. And under that sort of rubric where I might give 250 or 300, or I treat a lot of patients like Dr. Van Nostrand does, sent to him because they have heart failure or kidney failure, where those clearances are going to be different. So in those sort of bias settings, yeah, I think it helps us. If I'm back in Kentucky where I grew up and I'm practicing on my own, I think the majority of the time I'm just going to give an empiric dose of radioactive iodine. And on the few that are complicated enough to do dosimetry, they probably should go to a center that has the whole multidisciplinary team. So I think it's a true statement, but I also think for most of the time practicing the way we normally do, the empiric dosing probably works about as well.
Good. That's helpful. That makes sense. Okay, so quickly to wrap up things here, we will go through some of the limitations and the strengths that the authors list about their study. So first of all, they do point out this is a retrospective design, and so there's some limitations with that. Also, the possibility of selection bias. We talked about that before, but the authors point out that this is hopefully minimal because, as Amali walked us through, these groups are fairly similar. They're quite comparable, so maybe not a big impact from a selection bias. Authors also point out that there are a relatively small number of patients. And then, as we've wrestled with already, they do point out that they think it's a strength that they included only patients prepared with a single method, though that did necessarily require excluding those 13 patients who had multiple methods of preparation with their multiple doses of radioactive iodine. So finally, with the conclusions, I want us to end with here of what the authors say. and then we'll give our thoughts based on that. So again, quote the authors. They say, we conclude that the mode of preparation for radioactive iodine therapy does not decisively affect the outcomes of radioactive iodine therapy of patients with metastatic differentiated thyroid cancer. And then finally, they state that future controlled studies are warranted. So we'll come back to that and in a second here and decide if we can change our practice, yes or no. But first of all, I just want to think about this, the quality of this overall. So Molly, we'll start with you. And what are your thoughts on just the quality of this report, how the authors got this data, wrestled with the data, the discussion that they came up with afterwards?
I think the authors did a great job. When I first read the description, in my mind, I was thinking, well, all the really complicated patients probably went to one attending who did one thing, and the other patients went to another attending who did a different thing. But as you said, they analyzed it, and it really wasn't the case. The two groups were very similar in many ways. And so I think that is certainly, as we said, we're not going to get a lot better evidence in this. So I really applaud them for tackling this question. And I think that it does a lot to help us better understand this question and what to do in this situation.
Mike, thoughts on the quality of this report overall?
Yeah, I think it's a good study. I mean, the ones of us that do these kind of retrospective studies wrestle with how do you compare the groups and those sorts of things. And I think the conclusions are pretty much right, that the groups were similar in what we could measure. They may or may not be similar in what we couldn't measure. If you look at my practice, where I use almost exclusively recombinant human TSH, there are selected patients that I'll make hypothyroid because I think they work better. That may not necessarily be in my note. It may be the same age, but it may be the size of the tumor. It may be sort of subtle things. Or worse, I may make them hypothyroid because I'm really worried that they're going to be a really difficult one to treat. So I could be biasing hypothyroid toward the more aggressive ones and only using recombinant human TSH in the easy ones, right? Now, I don't know if that's right or wrong, but I'd be biasing that. So I still think there's quite a few biases that are probably selecting people one way or the other, but maybe not so much in a group that sort of uses a lot of recombinant human TSH and dosimetry. If I was the reviewer and was quibbling on the author's conclusion, I would have had them, they wrote, we conclude that the mode of preparation for RAI therapy does not decisively affect, they use the word outcomes. I would have had them put short-term progression-free survival, because outcomes is true, but the outcome of interest that I'm most convinced of, and I think the thing that would help community endocrinologists and all of us that are practicing clinical medicine, is this study builds on a host of retrospective studies that they define in their discussion. They do a good job citing all the papers that we've published, other people have published, same relative size, same sort of 5-year outcomes. And I think you take away from it saying at least over the first 5 years, the progression-free survival is going to be about the same if you do thyroid hormone withdrawal or hypothyroidism. That's pretty strong, right? That's a good conclusion to make. And you can talk to a patient and say, here's the two ways. And we know at least over the first 5 years, you're no more likely to grow or shrink or those sorts of things. So to me, I think that would open the door to people to say, yeah, this is sort of a reasonable thing to do. But it also recognizes that we don't know tons of data over 10 or 15-year overall survival. We don't know the side effects of radioactive iodine. So when we're trying to move things from theoretical to really clinical based, I think there's a lot of patients, particularly older patients, that said, yeah, you get me 5 years progression-free survival, I'll take that and not have to be hypothyroid, right? Or some of our young professionals that don't want to be hypothyroid for 2 or 3 months in their job and college and that kind of stuff. They may elect to do that. Younger, small volume disease should be treated with radioactive iodine very well. So I think the take-home message for me is we can feel really good that progression-free survival over the first few years is the same, and then use that as sort of one additional piece of information when you're trying to help the patient balance sort of what's the risk and the benefits, understanding that the gold standard is still thyroid hormone withdrawal, even though I've made the decision not to do the gold standard most of the time. But when you're old and gray-haired and have the ego that I do, that seems like an okay thing to do.
All right, so Mike, you've given us some thoughts about how you might do that, but maybe take a different perspective as we end here and thinking about, okay, changing our practice. So maybe not just you and the patients that you see, but you do a lot of work with guideline writing, and certainly not asking you to reveal anything that may or may not be coming out of the newest version of the thyroid cancer guidelines. But as you think about this from a broader perspective, so not just somebody who sees these folks, numerous of these people every day, but maybe the folks like Molly or me who see a fair amount, but not like you do, who really rely on the guidelines to help us understand this. Would you say, looking at this and then putting this information in context of the information that's out there, do we have enough to where we can make some recommendations like that? Or would we say, like the author say, well, we really do need future controlled studies, understanding, as you've already pointed out, that those may be really hard or even impossible to come by in the future. So help us understand, should this change our practice, or we need to hold tight and wait before we can make broader recommendations?
If I was looking at this data, I still think from a guidelines perspective, without long-term overall survival, without much more data, without the randomized trial, hypothyroid withdrawal is going to stay the mainstream standard of care. But I think it's reassuring that there are many patients, for a variety of reasons, that would opt not to do that. And I'd feel very comfortable treating them with recombinant human TSH, particularly the ones that you think are more likely to respond to the radioactive iodine, the smaller volume, RAI, AVID, that kind of stuff. So I suspect if I was writing the guidelines this time, I would try to make it a little bit more liberal. Right now, it's sort of like the patient almost has to have such terrible comorbid conditions that they couldn't be hypothyroid. I would leave those in. And then I'd probably put in some patient preference sort of stuff and balance of benefit, recognizing that progression-free survival. So I suspect the guidelines are probably going to leave you where we are right now without a strong recommendation to do it, but also recognizing that many of us are doing it. So I suspect you'll either end up with a no recommendation or maybe an expert opinion. But at this point, I think still for most of us that are practicing for our regular first-time distant metastasis RAI avid dose, probably hypothyroid is still the most traditional, safest way to go. Although you can tell from my bias is that the recombinant TSH would be fine. But when you get at that guidelines, it has to be more than bias and sort of personal opinion and individual expertise. So more worldwide, I think.
And with that, I would like to thank Molly Saracina and Mike Tuttle for joining me for this month's edition of Endocrine Feedback Loop. I hope you all learned as much as I did and that you join us again next month. And now you're in the loop. This has been Endocrine Feedback Loop. Endocrine Feedback Loop is brought to you as a members-only benefit of Endocrine Society with special production oversight by Maggie Graham.